Hi everyone, welcome to researchmd.com. We have a great presentation today. We're going to teach you all about what we need to know about back pain. It's going to be an evidence-based review, and we're going to do this in 9 minutes. We understand the importance of time. If you had to review this again, you could go back and review. Again, my name is Pramil Cheriyath. I'm a program director in internal medicine residency program, transitional residency program. I teach medical students and residents. I'm also director of research. Okay, if you look at back pain, very common diagnosis, lifetime prevalence report to be close to 80%. I mean, it's one of the most common complaint the doctors, patients usually go to the doctor's office or come to the emergency room. Risk factors, age greater than 30 years, physical inactivity, obesity, arthritis, osteoporosis, pregnancy, smoking. You got psychosocial factors like stress and depression. Of course, there's occupational factors, heavy lifting, bending, twisting, whole body vibration, just like, when you have like a truck driver, long distance, and the poor posture, of course. So if you look at the pathophysiology, it's like, again, it's a wide range of pathophysiology can happen. So we're going to look at some of the common causes and all that. First one is a radicular pain. That is the most common. There's like herniated disc. That's what's happening in the spinal stenosis. You can have a bulging on protruding disc. You can have ligamentous hypertrophy. Then you got vertebrogenic causes, usually seen in the elderly patients in the compression fractures. Then you got muscle or facial ligament problem, foraminal stenosis, and then psychophysial joint, that usually due to osteoarthritis kind of changes. Of course, there's malignancy, could cause like a mass effect, or it can break down of the spinal vertebrae. There is infections, and then autoimmune diseases like inflammation, example I would say ankylosing spondylitis. If you take the history, you need to know what is acute low back pain or subacute. If it is less than 4 weeks, it's considered as acute low back pain. 4 to 12 weeks is like a subacute, and then other than you can say chronic back pain. The first thing when you think about when somebody comes with a red flag, you need to look what are the red flags of back pain. That is my priority. When I see a patient, or when you see a patient, or thinking about back pain, you have to rule out all the causes what causing red flag. That's an emergency. If you don't act on it, that's like a huge consequences later. So let's look at the red flags. Age greater than 50 years. So anytime somebody comes with age in grade 50, be careful. There might be something else kind of going on. Associated with the fever, chills, right? There could be an infection going on we need to worry about. The recent urinary tract or skin infection, again, it's a red flag. Penetrating wound near spine, significant trauma, unrelenting night pain or pain at rest. Most of the pain, when you lie down for a few minutes, it go away. If you're having back pain and if you lie down, the pain doesn't go away after like few minutes, then that is not a good sign, okay? And progressive motor and sensory deficit, like if somebody come in and say like I'm having leg weakness, that's like emergency. Saddle anesthesia, bilateral sciatica. Bilateral sciatica, most of the time you have sciatica, it's usually only like one leg. Anytime somebody said I'm having shooting pain to both legs, that's a red flag. The reason for that, for the disc prolapse to happen, both sides, the disc has to be prolapsed on both sides. That's like very unusual. Most of the time it happens on one side, and the patient can have like shooting pain, but to have a massive disc prolapse has to be there to shooting the both legs, okay? Difficulty urinating or fecal incontinence, that's a very, very bad sign, which we will come back and talk to you. Unexplained weight loss, you have to talk about malignancy. History of cancer, very serious, like history of osteoporosis, you can have fractures, immunosuppression, chronic oral steroid use also can lead to fracture. Intravenous drug abuse, you can have like abscess, substance abuse, failure to improve after 6 weeks of conservative therapy, also is a red flag. Now, past medical history, make sure you always ask the patient history of any type of cancer. You ask about osteoporosis, recent infection, prolonged corticosteroid use, and any history of ankylosing spondylitis and morning stiffness, back pain that improve with exercise, back pain unrelieved, patient is supine. All those past medical history, you have to know. Always kind of remember autoimmune diseases like ankylosing spondylitis also you have to. And medications, oral steroids, be careful, that can cause like fractures. Social history, smoking, alcohol use, and history of IV drug abuse is very, very important. And psychosocial factors, depression, stress, anxiety, maladaptive coping behavior, we need to know. We have to pay occupational history, take your time to get the history, like heavy lifting, bending, twisting, wall-body vibrations such as truck driving, job dissatisfaction, unemployment. And the sexual history, like there are several reports, 72% report less sex due to back pain, 70% report decreased satisfaction in sex life. So when you come to examination, of the general examination, you look for fever, cachexia, gait problems is very important. And the main thing you have to focus on, let's do the back examination first. Inspection of the back for abnormalities, scoliosis, high-grade spondylosis is very common, right? Tenderness, if you kind of press on the back and then you feel tenderness, you have to worry about vertebral fracture. Infection or neoplasm is very common. Spinal range of action, like if they cannot bend forward, and the problem ankylosing spondylitis is but usually associated with the back stiffness also. In the neurological examination is also very important. You do the straight leg test, there is ipsilateral and contralateral, and the cross straight leg test. Sensory loss, you check for weakness, decreased muscle control, altered muscle tone of the rectal tone, spasticity or clonus, and impaired angle or patellar reflex. In the next lab, we look in the evidence and see what is the likelihood ratio, what are the odds you can have the diseases, okay? Which one give you the highest odds? Like, so if we look at, lumbar disc herniation, that's the most common. The patient usually come with a doctor, right? So how can you, rule in this patient having sciatica has come with the back pain? So the first thing you have to look, which one give you the highest likelihood ratio? In this symptoms, the highest likelihood ratio is contralateral straight leg test raising, okay? That give you 2.5 likelihood ratio. That means like your odds kind of go up to like 15 to 20% of your diagnosis having back pain, okay? And then you can ipsilateral SLR likelihood ratio is 1.33. Then you have angle dorsiflexion weakness is 1.17. Great toe extensor weakness is 1.67. So all of this likelihood ratio kind of tell you the patient has disc herniation or not for sciatica. The other thing we talk about, the biggest red flags, is Cauda Equina, or the spinal cord compression, right? What are the evidence-based diagnosis? So you have to, in physical examination, if there's like urinary retention greater than 500 ml, the likelihood ratio is like 16.5. The main, but before that main, if you have bulbocavernous reflex, that's almost 100 likelihood ratio. It's very, very predictive of spinal cord compression, okay? So how do you do bulbocavernous? You can do like squeeze on the penis. You can do, pulling on the, if there's a patient have a Foley catheter, you can pull it on, and then you look at the anal sphincter, winking, and then that's the, so remember, bulbocavernous give you 100 likelihood ratio, okay? Rectal tone give you 5.71 likelihood ratio, urinary retention 16.5, and then bilateral increase in reflexes is 1.57. So very important, okay? Rectal exam, always look for sphincter tone, and the labs you do CBC, complete metabolic profile, ESR, C-reactive protein is important. X-ray, not routinely done, okay? So age greater than 50 years, and the morning stiffness, waking with the pain in sleep, any red flag kind of symptoms, then you can do, okay? MRI, again, not routinely recommended. If there is red flags presented, you should do. Definitely, if there is red flags, you should do it, okay? Treatment, I would go with Tylenol and Tramadol. That probably the best treatment, and then exercise, physical therapy, of course, and the question comes into bed rest and normal activity. Routinely is not recommended. Studies have shown that it does not help if you take bed rest. It may even worsen, okay? So advice to remain active, that is the current advice. So thank you so much for watching. We'll be back with another presentation. Please subscribe to the channel, and please also press the like button. Thank you very much. Bye-bye.